Dr. T L N Praveen garu for sir's presentation.
It's my immense pleasure to welcome Praveen sir to give his talk on evaluation of the ovarian masses based upon the guideline based approach, and whatever is there on the slide is just not enough. So he's one of the most senior, most teachers we have.
Before I start, I would like to thank Dr. Radha Lakshmi garu, Venkatraman garu for giving me this opportunity to participate in this Kurnool OBGY Society meeting. Today I've been asked to talk to you about IOTA as well as the ORADs. One most important thing I would like to have it is this. We all know in our day-to-day practice we keep evaluating adnexal masses. Let it be an ovarian mass or an adnexal mass. The first and foremost thing which we have to evaluate or to sort out is to categorize them as benign or malignant lesions. That is one of the most important things that we have to do. In order to achieve this, the IOTA, that is the International Ovarian Tumor Analysis Group, as well as the ORADs, that is the American College of Radiology Group, have put forward protocols which can help us in differentiating the adnexal masses as benign and malignant lesions. Now, why should we differentiate between these two? That is, whether it is a benign mass or a malignant mass. The reason is that whenever you identify a benign lesion, you are sure that you don't need to be aggressive. You can be, you can go, take certain, what do you call it as the less aggressive, conservative management. Whereas if it is a malignant lesions, then you need to be aggressive and you need to send them for a gynec-oncologist consultation. That is the reason why we need to categorize these lesions as benign as well as malignant lesions. Now, once we come to the IOTA ORADs, what happens is this not only categorizes these lesions as benign and malignant, but it also helps us in homogenizing, that is, standardizing our reporting pattern. Why do you need to standardize the reporting pattern? The reason why we need to standardize the reporting pattern is basically to come at an accurate diagnosis. That is one most important thing. Now, with the ORADs being added with the IOTA classification, it has now enhanced our ability to plan our surveillance management of these adnexal lesions. That is one of the additional features that we have with the addition of ORADs to the IOTA group classification. Now, today's my presentation is basically, it is to predict the risk of malignancy. That is one of the most important things that I am going to focus upon. To categorize these adnexal lesions as benign or functional lesions, or it is a malignant or invasive lesions or metastatic lesions. So this is the main aim. In order to achieve that, I would like to depend upon what is called as the IOTA classification. This IOTA group has come forward with certain terms which are defined and the measurements that can be used in evaluating various adnexal lesions. That is one. Second most important thing is they have formulated what is called as the easy descriptors or the pattern recognitions. There are certain adnexal lesions, by just seeing at them, you can give a differential diagnosis, or you can give a diagnosis. You don't even need to give a differential diagnosis. There is no need for a histopathology. So those are certain lesions which very clearly delineate that their morphological features are highly suggestive of a particular lesion. That is one. That is what is called as the easy descriptors or pattern recognition. Then comes what is called as the simple rules. They have come forward with simple rules. That is, each of the adnexal lesions will have certain benign features and certain malignant features. Based on that also you can categorize these lesions. Then last and the most important thing is what is called as the adnex model, which I will take you through by giving you some examples. Then we have the ORAD system. ORAD system is nothing but wherein they use the same easy descriptors or the terminology that has been used by the IOTA. Not only that, they have introduced certain lexicons, that is the IOTA lexicons or the ORAD lexicons, which are additional features which they are going to depend upon, and they have categorized these lesions, the adnexal lesions, into 6 groups. That is ORAD score 1, 2 and 6. So in that format they have categorized them, so that based on that you can plan your surveillance as well as the management. So that's what my aim is, to take you through and give you some clinical examples and give you certain key messages. Now, the IOTA group, that is, as I said, the IOTA is the International Ovarian Tumor Analysis Group. They have published a consensus statement in the year 2000, wherein they have defined certain terms, and they have defined those terms, and they have also indicated the way we are going to measure these adnexal lesions. And not only that, based on this, they have come forward with certain categorization of these adnexal lesions as benign and malignant lesions. That is one. The most important factor that they have suggested when we are trying to evaluate an adnexal mass is basically to evaluate through transvaginal approach. This is one thing which we have to be very, very clear. Dr. Gayatri has today morning told us about the advantages and disadvantages of both transvaginal and transabdominal. Now, the transabdominal, except for lesions which are very big, wherein you cannot evaluate them transvaginally because of the limitations as far as the depth is concerned, I would prefer to do transvaginal for every lady who comes for a pelvic scan. There is no compromise in it. In case if there is a contraindication, or in case if you have a non-consumed lady, in that situation I would prefer to do a transrectal rather than a transabdominal scan. This is one message which I wanted to very clearly send it across, because that is the way you are going to evaluate the adnexal lesion. Why so? The reason is, one most important thing is that you are going to evaluate these adnexal lesions from a closer proximity, and you are using higher frequency. Because you are using higher frequency, you have a better resolution. Then you have what are called as the soft markers, that is, you can mobilize the lesion, that is, you can use the factors such as the mobility as well as the site-specific tenderness by doing a transvaginal scan, which cannot be done by doing a transabdominal scan. So these are the certain advantages which we have by doing it. So that is the reason why they have very clearly specified that it has to be approached transvaginally. That one. Second most important thing which I want to tell you is that quite often if you go through all the literature, the need for 3D is absolutely very, very minimal, or I would say it is not, negligible. Whereas the most important factor that when you are trying to evaluate the adnexal lesions, it is basically the grayscale as well as the color Doppler. So most of our equipment which we quite often use in evaluating these pelvic lesions is basically incorporated with grayscale as well as the color Doppler. So we don't need a very high-end machine where you need a 3D acquisition and all. So that is one message which I wanted. So transvaginal, grayscale, color Doppler. That's it. These are the things that are required whenever you are trying to evaluate an adnexal lesion. Now, next comes what are these IOTA terms as well as the definitions. What they have done is they have postulated each of these lesions or categorized each of the lesions based on the presence or absence of the locules, presence or absence of the solid component, the cyst content. Then they said about the cyst wall, the internal cyst wall and the external cyst wall, presence or absence of the papillations, vascularity of the lesions, because the vascularity is an extremely important thing. And then comes the shadowing, presence or absence of shadowing. Whenever you see shadowing, you know that you are dealing with a calcific area, and then whether there is presence or absence of the ascites. These are the terms that we have to be very, very clear about. So they have said that these are the terms that are used in order to categorize these lesions, and they have given when do we call, what is it called as. So for example, we have the loculations. When you talk about the locularity or the cyst content, basically you can categorize these lesions. As you can see here, this is a classical unilocular cyst. You agree with me? There is no locule, there is a well circumscribed lesion, the internal wall is absolutely smooth and clear and normal, and then you don't find any papillations or any calcification. So this is a classical unilocular cyst, whereas this cyst can also be associated with some amount of solid component, then you call it as unilocular solid lesion. See, remember this, the term of complex adnexal mass has gone. You should not use complex adnexal mass. That's not the way you are going to describe an adnexal lesion. There are specific terms that have been intended, and this is how you are going to evaluate these lesions. So next is the multilocular one. That is, you have a multilocular cyst where there is no solid component, or you may have a multilocular cyst with the presence of solid component, or the lesion can be absolutely solid. Now, see, why are we worried about the solid component? Because the presence of solid component definitely increases the incidence of malignancy. That is the reason why we need to be very cautious. When do you call it a lesion, a solid lesion? When more than 80% of the lesion is consistent with the solid component, then we call it as a solid lesion. So these are the definitions that that are very, very clearly delineated in order to evaluate this adnexal. Now, coming to the cyst content. The cyst content can be absolutely anechoic, that is, you don't find any echoes within the cyst, then you call it as an anechoic cyst, or you may have a low-level echoes like this, as you can see here, which could be because of the low-level echoes, and then it can be a ground glass appearance. This is another classical example wherein you may have a ground glass cystic content. Then we may have a spider web appearance, that is, multiple thin septations can be seen within the cyst, or you may have a mixed echoic, that is, you may have a hyperechoic, hypoechoic, anechoic areas within the same solid lesion or within the same adnexal lesion. So these are the various types of cyst content that has been described. So when you try to evaluate a lesion, adnexal lesion, these are the terms that you have to be used, and these are the terms which are going to tell us about the nature of the lesion, morphology of the lesion. Then comes the internal wall. The internal wall, whenever it is smooth and regular, it quite often is a benign lesion. Whenever it has a papillary projections or a solid component, as you can see, which causes irregularity of the internal cyst wall, then it could be a malignant lesion. Now, when it comes to the external wall, particularly when we are dealing with a solid lesions, in that situation, whenever you have a solid lesion with a smooth outline or a regular outline, it is usually a benign lesion. Whenever you have a lesion which is solid but which has a lobulated appearance like this, it has to be a malignant lesion. So these are certain few terms and definitions that they have given. Now, coming to calling what is a solid component. A solid component is nothing but an echogenicity of the tissue. That is one. So if you say that this is a classical example, someone tell me what is this classical example of? You have a well circumscribed cyst, you have a cystic component, you have a moderate echoes, and then you have a white ball. So this is classical dermoid. So this sort of a white ball which is seen in the dermoid, which is basically because of the fatty tissue, and it is not called as solid. That is one thing which you have to remember very well. Second important thing is whenever you are dealing with a clot within the cyst, then also that is not a solid component, it is a clot. Then we have a mucin plug. In the mucinous cystadenomas, you have a mucin plug that is not solid, that is only a mucin plug. So this is how they have categorized the solid lesions. Then we have papillary projections. Whenever we see a papillary projections, if the papillary projections is more than 3 millimeters in length, that is the diameter, and at the same time it is engulfed with fluid on all sides, then you call it as a papillary projections. Whereas when you see small subtle projections, which you can see here, which is called as the internal wall irregularity, it is not called as a papillary projection. So these are very, very specific terms that we can use. If you can you can start using these terms in your day-to-day practice while evaluating the adnexal lesions, I am sure it should not be a problem to differentiate one from the other. That is then comes the vascularity. Vascularity is an extremely important, as I'm sure you all will agree with me, whenever there is an increased vascularity, our minds will immediately think in terms of a possible malignant lesion, isn't it? So whenever we try to evaluate the vascularity of an adnexal lesion, the most important thing is we need to be very, very appropriate with our technical factors, that is your settings, that is the vascular, that is the Doppler settings which you are going to use. For that, most often what we can use is either a color Doppler or a power Doppler, preferably a power Doppler, because power Doppler has got higher sensitivity. The reason is that the flow in the pelvic vessels are slow flow. The flow which is very, very low, in that situation you need to appropriately set your settings so that you can appreciate the vascularity. Second important thing is the size of the color box. You know, all of us, we use color box. You should not use a large color box. You should not use a very small color box. The color box should be appropriate, because if the color box is appropriate, the frame rates will be maintained. If you use a large color box, that means you are asking the machine to work more. If it works more, the frame rates drop down. So your visualization or the vascularity will become very poor. So that is the reason why you need to have an appropriate color box. Then you have to have a color gain. Color gain also, you should not have a splash of colors, or you should not have a bleeding in the vessels, but you should have an appropriate color gains in order to appreciate the vascularity. We have to always adjust the PRF, that is the pulse repetitive frequency, which can be easily toggled from 0.6 to 0.3. Quite often I use about 0.6 kilohertz, and that is the time when you can appreciate slow flows also. If you use a PRF at 1.2 or 1.3, then your color flow will not be seen. That is the reason why you need to have an appropriate color flow. Then wall filter and balance, usually we don't tamper taper with, but then these are the wall filter should be about 100, balance should be about 220. Now, how do we score these colors? Now, most often we all know that whenever we try to evaluate the color in an adnexal lesion, we can score them as no flow when you can't demonstrate any vascularity in the lesion, then you call it as color score 1. Then we have a minimal flow in the lesion, then you call it as color score 2. And similarly, moderate is color score 3 and abundant is color score 4. So this is a subjective parameter. You may ask me that how are you going to use this subjective parameter? That is, I may say it is color score 2 and you may say it is color score 4. So that is the reason why you can still have what is called as the vascularity flow index. But then quite often for evaluating adnexal lesions, vascularity, whether it is color score 3 or color score 4, it really doesn't matter, because if I take you to the adnex model, I really don't even use the color scores at all. So that is the reason why I don't give much importance. But then you need to understand this one. So these are the ones. Here you have a lesion where I have put the color box. The color box is appropriate. I have set the PRF appropriately, but I don't find any vessels there. So this is color score 1. Okay? Whereas here you have a lesion where there are not much of vascularity, but there are minimal vascularity. It is color score 2. Whereas here we have slightly moderate increase in the color scores, so color vascularity, so it is color score 3. Whereas here you have an abundant vascularity, which is typical of a color score 4. So this is how you are subjectively going to assess the vascularity of the adnexal lesions. Right. Then comes the shadowing. Shadowing is an extremely important, because we all know whenever we have an adnexal lesion which has a calcific area, quite often our mind will think in terms of a benign lesion. So that is the reason why shadowing and calcification are extremely here. This calcification can be a dense calcification, as you can see here, or it can be a very subtle shadowing that you can see here. So these are the two different types of shadowing that you may come across in your practice. So this is one thing which we have to identify. Then comes the presence or absence of fluid in the peritoneum, that is the ascites. Whenever the fluid extends beyond the Douglas pouch, above the fundus of the uterus, you call it as ascites, or when you find fluid in the Morrison's pouch, you call it as ascites. So these are the situations where you label them as that. Now I have used all the terminology which is going to be used in our description of an adnexal lesion. So this is the pattern that you are going to make use of. Now once we have done that, in order to categorize these lesions or identify these lesions, is basically 50% of the adnexal lesions can be easily, instantaneously identified with the pathology. So that is one of the most important thing, and that is what is called as the pattern recognition or easy descriptors. In the premenopausal group, we have what is called as the physiological or hemorrhagic cyst, or it can be a simple ovarian cyst, or it can be a dermoid, or it can be an endometriomas. Whereas in a postmenopausal woman, where we have a solid lesion with a color score 4, that is abundant vascularity, you know that you are dealing with a ovarian malignancy. So I will take you through each of these things. This is a classical easy descriptor. Now once this imprints in your mind, there is no way that you are going to miss this one. So here we have a well circumscribed unilocular premenopausal woman, cystic area with what is called as the spider web appearance, isn't it? These are all thin septations which are seen. Now I am using the same transvaginal transducer. I am trying to push the solid looking lesion which is wobbling with my pushing. So this is a clot. So this is a typical appearance of a hemorrhagic cyst. So once you have seen this one, and once you have identified the features which are suggestive of a hemorrhagic cyst, this is what is called as easy descriptors or pattern recognition. This pattern can never be forgotten. Next comes the lesion here. We have a very well circumscribed unilocular. The size of the cyst is less than 10 centimeters, and the internal walls are absolutely smooth and clear, regular. So this is a classical simple ovarian cyst. Then comes this one. Here we have a unilocular with a ground glass cystic appearance. Very, very typical. You know that this is if you see this in a premenopausal lady, you know that you are dealing with an endometrioma. So this is very, very typical. So this again is a pattern recognition or easy descriptor. Then we have this sort of a lesion where there is a mixed echogenicity, where you have a solid looking lesion but not a solid, but it has a subtle shadowing. So it is a very typical of a dermoid or a teratoma. then we have this sort of a lesion where we have a solid lesion. It is because the more than 80% of the lesion is solid, and we have increased vascularity, color score almost 4. That is definitely an ovarian malignancy. So these are the pattern recognitions that can help us in 50% of the adnexal lesions can be categorized just based on these features. So this is one thing which we have to be very, very clear. Okay, now we have tried the pattern recognition, but there are certain adnexal lesions which are not going to fall into this pattern recognition. In that situation, what are we going to do? We are going to depend upon what are called as the simple rules. These simple rules are categorized as M features and B features. M features are nothing but the malignant features. B features are nothing but the benign features. What do you mean by M features and malignant features? That is, the features which are highly suggestive of a malignant lesion are called as M features. The features which are suggestive of a benign lesion is called as a benign feature. So I'll show you some of the examples so that you can understand. This is a classical one. Here we have B features from B1 to B5. Okay, whenever we have a unilocular cyst which is well circumscribed, internal wall is absolutely clear, there is no solid component, it is less than 10 centimeters in diameter. This is what is called as the unilocular cyst, which is B1. Then we have a small solid component which is called as an irregularity. I showed you when I showed you the papillations within the cyst, whenever you have a small projection like this is not called as a papilla, it is called as an irregularity. So the internal wall is irregular, but I put the color Doppler on and I don't find the color at all. So it is definitely a benign lesion. So it is B2. Then we have a acoustic shadowing, which is very typical, which is B3, and we have a multilocular cyst which is less than 10 centimeters without any solid component. This is what is called as the benign feature 4. And whenever we have a lesion which is when the color Doppler is applied, we have color score 1, we call it as B5. So these are all the B features. So whenever you have an adnexal lesion, you try to follow these features, then you can come to a conclusion. I will give you some examples so that you can understand them better. These are all the M features. M features is irregular lobulated solid mass. Then we have the ascites. Then we have papillary projections which are more than 4. Then we have solid component with multilocular cyst, and we have abundant vascularity. So these are all called as the M features. Now the problem comes is when we have one or two or one or more M features, we definitely know how we can label it as a malignant lesion. If we have one or two benign features, we label it as a benign lesion. But then we may be in a situation where you don't have any features, or you may have one benign feature and one malignant feature. Then it becomes inconclusive or uncertain. So that is the situation which we are going to face. That is, whenever we have that sort of a thing, you label them as inconclusive. Now, using these simple rules, almost another 25% of the adnexal lesions can be cleared. So 50% of them can be identified using pattern recognition, 25% of them can be identified by using simple rules, and there are only 25% more of adnexal lesions which require further evaluation. So that's where we are going to concentrate upon. And then the sensitivity of identifying benign and malignant lesions is very, very high. It is almost 92%, and specificity is 96%, and only 25% of the adnexal masses are called as uncertain. And this is when, then what are we going to do? In that situation, what we are going to do is we need to consider there are three possibilities that we can have. There are three options which we have. One, you consider all of them as malignant because 40% of them are definitely malignant. That is one option. Second option is refer to an expert so that he will give you a better diagnosis. Or three, use what is called as the adnex model. This adnex model has been published in 2015. I will show you what this adnex model is. This adnex model is nothing but assessment of different neoplasms in the adnexa. This is what is called as the adnex model, in which that can help us in differentiating between a benign lesion, borderline lesion, stage 1 malignancy, stage 2 to stage 4 malignancy, or metastatic deposit. So this is how we can categorize each of these lesions. So this 25% of lesions which were inconclusive on our simple rules are the ones which are subjected to adnex model. Fortunately, previously we used to have what is called this adnex model was available as an app or also as a web application, but unfortunately it has been removed because of certain European device regulations where they needed certification. So that is the reason why it is now available only in high-end equipment. Now, this is what exactly the adnex model looks like, wherein there are three clinical components and almost six ultrasound variables. The three clinical components are the age of the patient, whether the CA 125 is done or not. Then the third one is the place from where you have the referral sent to. So that is one. These are the three components. The six ultrasound components that are used in evaluating these adnex masses are maximum diameter of the lesion, proportion of the solid component, more than 10 cystic locules, number of papillary projections, acoustic shadowing, plus or minus, or ascites. So these are the six. Now you can identify that, as I told you before, I have not given any importance to the color at all in this particular adnex model. So color, yes, it is going to be helpful in identifying the vascularity, but it is not essential in order to categorize this 25% of the adnex lesions which were inconclusive by using either the pattern recognition or by using the simple rules. So these are the things that we are going to address by using what is called as the adnex model. I'll give you one example wherein you can understand how we are going to use. This is a 40-year-old female who has presented to us as a unilocular solid. You can appreciate that this is a unilocular solid mass or a solid cyst, and the maximum diameter of it was about 67 millimeters. Definitely it falls into a benign lesion, and then the diameter of the solid component is almost about 19 millimeters. There are no locules in it, but there are more than 3 papillary projections. You can see that there are multiple papillary projections, there were more than 3 papillary projections, and then there is no acoustic shadowing or ascites. So what we did, we have put that on to the adnex model, wherein we have identified the age. We have also identified the various things like this: the maximum diameter of the lesion, maximum diameter of the solid component, presence of locules or not. All those things are fed into this adnex model, so that it gives you a description like this. This is how it is. How are we going to interpret this? Okay, it's fine, wonderful, it's looking very colorful also, but then this is the way we are going to identify these lesions. Now here, the same patient, it indicates that almost 50.3% of these lesions are categorized as benign, but 49.7% of them are considered as malignant. Now let us get to the patient-specific risk. Whenever we come to the patient-specific risk, what we take it as the cutoff as 10%. Anything more than 10% is considered to be malignant. Anything less than 10% is considered to be either intermediate or low risk for malignancy. That is one most important factor that you have to understand. The second thing is, there are certain institutes which use 25 as the threshold. So you can use that also. But then hence it is because of this, as we can see that it is more than 10% here, we definitely consider this as a malignant lesion, and then the risk of borderline lesion is almost 4.1. Patient-specific risk for that particular one is almost 26%. So this is how you are going to interpret this adnex model, and this gives you that the adnex tells us that it is a malignant borderline lesion, and this turned out to be a borderline serous tumor. So this is how you are going to use the adnex model in your day-to-day practice. Now then comes the ORADS. ORADS is nothing but the one which has been formed in collaboration with American College of Radiology. ORADS is nothing but ovarian adnexal imaging reporting data system, in which what they have done is they have used various categories. By using ORADS, they have amalgamated with the IOTA terminology as well as the simple descriptors or the easy descriptors as well as the simple rules. They have added certain descriptions such as the hydrosalpinx, para-ovarian cyst into their lexicon. This is what is called as the ORAD lexicon. Putting all those things into consideration, they have given a score, risk score for malignancy. This is how it looks like. Now this is the risk score for malignancy, where whenever you score, ORAD score is 0 to 5, that is 6 grading is there, and the risk of prediction is basically based on, they have taken into consideration the IOTA model, they have taken into consideration the lexicon descriptions as well as the IOTA description, and then they have identified the monitoring or surveillance as well as the management which you are going to advise these patients. So this is a total comprehensive evaluation of adnexal lesions, wherein whenever you think in terms of a ORAD 0, that is score 0, basically you have done an inconclusive exam. examination. The reason is that you have not been able to identify the lesion thoroughly, maybe because of the bubble loops or maybe because it is a very large mass. In that situation, you need to repeat the examination both transvaginally, transabdominally, or advise for an MRI. That is one thing which they have advised as far as the management strategy is concerned. Then we have a ORAD score 1, in which we have follicle, which is a normal functional component of the ovary, or it may have a corpus luteum in a premenopausal woman. These are the patients who are scored as score 1, and in this one the follow-up is none, because you don't need to follow up a follicle or a follicular cyst. So that is the reason why they have suggested that there is no need for any management. Whereas when you have a ORAD score 2, it is absolutely normal. That is, it is absolutely benign, because, as I said, the risk of malignancy is less than 1%. When once you have a risk of malignancy, anything more than 10% is definitely suggestive of malignancy, whereas anything less than 10% is considered as benign. So here we have a risk of malignancy based on the aorta adnex model is less than 1%. So positively it is a benign lesion. These are all the descriptors, that is the easy descriptors, simple rules, as well as the lexicon descriptors, which I have already discussed with you. So making use of them, then you may need to categorize. I'll tell you the management strategies also in this. Then whenever you have a low risk that is less than 10, but then it has to be regularly followed up. Now when it comes to the follow-up as far as the ORADs is concerned, in ORAD score 0, repeat ultrasound examination. In ORAD 1, there is no further follow-up. In ORAD 2, no further follow-up or ultrasound surveillance, but second opinion from an ultrasound specialist or an MRI may be required in certain cases. Whenever there is ORAD 3, that is, which is the risk is almost about 1 to 10, that is the risk of malignancy is between 1 to 10, repeat ultrasound examination by an ultrasound specialist or an MRI and refer to a gynecologist. If it is ORAD 4, that is score 4, repeat ultrasound, that is when you have a risk of malignancy between 10 to 50. In that situation, refer the patient refer to a special ultrasound specialist or do an MRI or refer to a gynecologist or a gynec oncologist. So these are the pattern. Now when you have a high risk, that is more than 50% risk of malignancy, in that situation you are going to refer directly to the gynec oncologist. So this is the pattern that has been suggested. So these are all again a summarization of what are all the things that we are going to do as far as managing these patients are concerned. Now I'll show you a few examples so that to drive across the method by which you can make use of it in your day-to-day practice. Now example 1, we have a 30-year-old female, pelvic discomfort, normal CA 125. On ultrasound, you know that you find that this is a unilocular solid which is about 110 millimeters, that is more than 10 centimeters. Solid component is almost about 48 millimeters, and there is no locule. Papillary projections are definitely more than 3. Color score, as you can see the color, there is no color score, there is no flow, so there is color score 1, there is no shadowing, there is no ascites. So in this situation, can we use pattern recognition? Is pattern recognition going to help us in identifying the lesion? No, isn't it? You know what are all the lesions which can be identified by using pattern recognition, or can we use a simple rules? So this is how we are going to. So now I have used the simple rules. Again in simple rules also, there is a solid component, there is a low vascularity, but there is a papillary projections which are more than 4. So again there are few malignant features and few benign features. That is the reason why I can't even use a simple rules in order to categorize these lesions. So this is the adnex mass which is going to fall into the category of 25% which are inconclusive, where you need to apply the adnex model. So I have applied the adnex model, and this is what the adnex model says, that it is almost the risk of malignancy is 63%. That definitely it indicates that it is more than 10 or it is more than 50. So ORAD score will be score 5. Isn't it high risk? So that is how you are going to categorize. Once you say that, then you can put it on to the ORAD. As I said, it is going to consider as high risk with this description. And what are all the things? So easy descriptors, no use. Simple rules, inconclusive. Adnex model shows that there is a malignancy risk of 63%. ORAD shows that there is 5 high score, that is very high score of malignancy. So management, you have to send it to a gynec oncologist, and this turned out to be a low-grade serous carcinoma. So this is how you are going to approach these lesions. I'll show you one or two, again, another lesions. Here, again, an example, very, very typical. You know that you can diagnose, all of you can diagnose, because I have shown you so many of these examples, wherein this is a 28-year-old premenopausal woman, lower abdominal fullness, CA 125 2.58. Now we have a lesion which is unilocular solid, and then it is 90 millimeters. There is, unilocular says there is no solid component, because I told you this is a white ball, which is not a solid component. And then there is a mixed echogenicity. There are cystic areas, mid-level echoes, as well as hyperechoic areas. Definitely there is a subtle shadowing, which is very, very typical. And this you can use pattern recognition or not. Can you use pattern recognition or not? Definitely you can use pattern recognition, and this pattern recognition tells us that it is a dermoid, isn't it? Now we can extend it and try to use the simple rules also in this case, wherein you can see that it is a unilocular B1. You have a presence of shadowing, acoustic shadowing, it is B5, and then we have very low flow, that is B6, B5. So these are the things that which definitely tells us that this lesion is a benign lesion. You put it on to the adnex model. Here we can see that the model predicts 99.8% to be a benign lesion, and this is how we are going to get whereas the ORAT shows that it is a absolutely, definitely a possibility of a benign lesion. ORAT score is 2. And based on this, easy descriptors, dermoid, simple rules, benign lesion, adnexal lesions, risk of malignancy is only 0.02, which is definitely less than 1, and then the ORAT score is 2, and certainly benign, and then the management is conservative management. This is a mature cystic dermoid, teratoma. Then comes another example where again a lesion which is little ambiguous, in the sense we are not very sure about using either the pattern recognition or the simple rules. In this situation again we have a 67-year-old postmenopausal woman presenting with bloating of the flare. What we have here is the unilocular solid mass, which is about 54 millimeters, more than 3 papillary projections. You can see so many papillary projections. When you put the color score, there is intensely color score, and then there is no evidence of shadowing or ascites. So we cannot use pattern recognition in identifying this lesion, definitely. Whereas if you can use the simple rules, it shows that it is a high possibility of malignancy, because there are no benign features, but there are 2 malignant features. So we know that we are dealing with a malignant lesion, but then we would like to know which sort of malignancy, because adnex model is the one which can tell you whether it is a benign malignant. If it is a malignant, is it a borderline, stage 1 malignancy, stage 2, stage 4 malignancy, or a metastatic tumor. So in that situation, here when you put that onto the adnex model, you can show that the overall risk is almost 94.4. That means definitely more than 50%. It is a high risk for malignancy. So with this, we have to adnex model, the ORAT very clearly delineates that it is a high risk model, and in this one what we have is easy descriptors have no role to play, whereas the simple rules have definitely categorized it as malignant lesion. Adnex risk malignancy is definitely 94.5, which is definitely more than 50%. ORAT score is 5, and then definitely we have to refer to her gynec oncologist, and this turned out to be a high grade serous ovarian cancer. So this is how you are going to approach. So to summarize the whole thing, I would like to tell you that easy descriptors, these are all the things that can, and that can give us an answer for about 50% of the adnexal lesions, whereas the simple rules like B, that is the B features and M features, will give you an answer for almost about another 25%, that it becomes to 75%. There are only about 25% which are inconclusive in spite of using pattern recognition and the simple rules. These are the 25% which are going to be subjected for adnex model as well as the ORATs in order to get the management. So this is the basic concept of using IOTA as well as the ORATs. Thank you very, very much.